Okay, I should see slides. Okay. Oops. Okay, so like I said, this week is just autism and schizophrenia. It's the last chapter that you'll be covering for the exam. So this is chapter 13. What the week looks like. So this is what I was saying just now. Ideally, we cover it in both days, but let's see how far we get. If we cover it all today, then that means Wednesday will be exam review, and then Friday can also be exam review, or we don't have to have class. So let's just see what today looks like. But regardless, Friday is mandatory, or sorry, is optional, not mandatory, because we will have that as our exam review. If we do end up starting exam review on Wednesday, it just means that Friday will be an additional day if people want to come, but definitely don't have to come. And then that means that a week from today, so on Monday, March 3rd, we do not have class, and that's because the exam opens and you have the full day to take it. So everything on the exam, or the stuff that's on the exam, is everything we've covered since the last exam. So that's chapters 9 through 13. So ADHD, ODD, the other externalizing problems. We started talking about communication disorders, specific learning disabilities, intellectual disabilities, and then whatever we cover this week. So that's everything for the exam. Since you've done your first assignment, I think, or I know that all of the assignment grades have been released at this point. So your assignments do not go into the exam. So they're separate. So there's nothing on the exam that will be something that we talked about for the assignment. So completely separate. Yeah, just examined like the last section that we did. So lectures and textbook readings. Okay, so again, reorienting you to where we are, we're still in the neurodevelopmental disorders category of the DSM. And so we're doing autism. We said this last week, we're not covering motor disorders. And then we're also covering schizophrenia, which doesn't show up in that list right there. So we'll start first with autism because that's really the meat of what we're talking about in the class when it comes to this section. In the DSM, so we have the intellectual disability section, and autism is kind of its own thing. There's not like an autism not otherwise specified. So we talked about that last week, how a lot of these disorders have kind of like a throwaway title, like unspecified or other specified, like you see down here. And autism does not have that. So it's its own thing, autism spectrum disorder. And that wasn't always the case. So right now we have only one section, which is called ASD, but previously, before the DSM-5, we used to have in DSM-4 a different title. So it was called pervasive developmental disorders. And there's been a shift. The reason why we have DSM-5, which is ASD, and why we used to have the pervasive developmental disorders, which included autistic disorder, Asperger's, pervasive developmental disorder, not otherwise specified, Rett's disorder, and child disintegrative disorder. The reason why we don't have that anymore is because this is a classic example of how the field, at least in this area, autism, has really pushed for a move away from categorical system to more dimensional, continuous views of psychopathology. So DSM-4 clearly has multiple different categories, which all fell into pervasive developmental disorders. Autistic disorder used to be its own thing, and then Asperger's was something very closely related, as are the rest of these disorders, but they were considered different. Moving into DSM-5, so 2013 and onward, now we can collapse all of that into one specific disorder, autism spectrum disorder. So what ASD does now is it collapses all the different 5 disorders we used to have, and it says that all of that can be represented on a continuum. So we think of ASD as a dimensional model, it's on a continuum. And so we can have lower to higher impairment, and the way that those things look can range based on where they fall on the severity continuum. So autistic disorder used to have impairment in social interaction, social communication, and those RRBs. And Asperger's was thought to kind of cover more of a like social model where it's more about the social interaction, social communication aspect of the first up here. And so people used to, this is not like what we would say in the field, but like, I think people like commonly would think that Asperger's is like the light version of autism. Again, this is using DSM-4 language because we think of autism or Asperger's as more of this social communication kind of difficulties in getting social cues, but maybe not to the extent of the severity of giving an autistic disorder diagnosis. So it seemed like those things were kind of arbitrary. There's research showing that that's, again, all along a continuum, which is why we ended up with one section in DSM-5, ASD, and it needs to encompass social interaction and communication plus the RRBs. So anybody that had been, like if you had gone to get an assessment and you got an Asperger's disorder label prior to 2013, if you were to go back now that it's been 12 years since DSM-5 has come out, and you were to test again, you wouldn't get a label of Asperger's. It would now be changed to autism. So there's a lot of people who say, oh, I still have Asperger's. It's just in terms of new language, it would fall under autism. So if you hear that term, Asperger's, it's ASD, it's autism, and it's one of the first examples that we have in terms of DSM shift with moving to a dimensional model. I put this note down here that social pragmatic communication disorder must be distinguished from ASD. So you can't label or can't give a diagnosis of one without making sure that it's not the other. So if you're going to give a diagnosis of social communication disorder, you have to rule out autism. If you're going to give an autism diagnosis, we got to make sure it's not social communication disorder. And we talked a little bit about that last week with the communication section. This is just a review and it's everything I just said. So why do we even care to collapse all those different disorders into one diagnostic category? It's because we have our research showing us that moving towards dimensional systems of diagnosis is the most probably as close to nature as we can get in terms of what our research is showing. And so we think of autism as being best conceptualized along a continuum of severity, and that's why you can have Asperger's on the lower end of maybe the social communication aspects of ASD, and then it varies all the way up until like low to high impairment. And the thing is, it's not just autism. That's what we think across all psychopathology. You could take I don't know, depression, and we would say there's a reason that depression varies so much. There's a reason why you have dysthymia versus depression versus some other mood disorder. And that's because it all lies along a continuum. So it's not just ASD specific, it's across the board. But again, ASD is one of the first places we saw it shift in the DSM. So again, this is the note. If you had a previous diagnosis of Asperger's in today's DSM-5 language, it would be ASD. And you would, if you went back for an assessment, you would get an ASD label. I'm going to save this video. It's just like it's from APA and it's just literally, what is autism? I think it's a helpful video if you don't know what it is, but we just covered it. I'm going to go back so you can see the diagnosis really quick. So this part down here on the last bullet, impairment in social interaction and communication and restricted repetitive behaviors, interests, or activities. Both of those must be met in order to get a diagnosis of autism. Of course, we have other criteria like must not be social communication disorder, needs to be impairing. So remember all the things that would warrant a diagnosis to begin with, impairing, developmentally inappropriate, what have you. Those are always going to be there, but for this, you have to meet both the social aspect criterion and you have to meet the RRB. So we talked about it last week in the sense that with social communication disorder, you really don't see the restricted and repetitive behaviors. So that's one way of differentiating between the two. So remember, you have to have both, not just one or the other. And this is different from other disorders like OCD, where obsessions and compulsions can be present, but they don't have to be. It could be one or the other. So autism is different in that we say both of these things must be occurring. So what do those things look like? So in terms of the social aspect, it involves communication and interactions. It might look a little bit different across different age ranges, and that's kind of like with everything, we expect things to look a little bit different in terms of chronological age, but also developmental age. So with young children, what we tend to see with this social aspect is decreased social interest. So maybe not as likely to respond to their name, not really being interested in like social figures in their environment, showing unusual responses to stimuli. So by unusual, just not the norm when it comes to what most people that age would do. So rather than like, I don't know, like being carried, like an aversion to being touched. You see a lot of research and people talking about eye contact. So there's like whether you can follow the gaze or whether you can hold a gaze, those kinds of things seem to be diminished. And then deficits in joint interaction tasks. So doing things together. So if I'm holding my baby and we're looking at this thing in front of me, like I'm holding a water bottle in one hand, I'm holding the baby in the other, and I'm looking at the water bottle. So lack of joint attention would be baby is not also looking at that, given that there's nothing else to look at. Lack of understanding of social cues and inappropriate social actions. So this can look like a variety of things, can be disinterest. So it's the reciprocity that's missing. Reciprocity is this back and forth when they're in a social interaction. So there's like if you think of a ping pong, like it's pinging and ponging back and forth. So a social interaction, a conversation is supposed to have that ping pong naturally, just coming back and forth. And so, with the social communication aspect, where we have maybe lower capacity to hold that in mind, it might feel really one-sided, like you're pinging and the ball keeps dropping. So it's just lack of social reciprocity, and also could be a sense of empathy. Now, I think it's important to say too, that's not to say that like there is no empathy. I think the perception, though, is that because the actions to show empathy are not there, it seems as though there's a lack of empathy. Um, Difficulty with subtleties of social interaction, so difficulty managing sarcasm or kind of reading between the lines. Um, Different things about like social group behavior. So if you're standing in a group of people with your friends and or if you're an outsider and you want to come join a group, what do you do with your circle? You're supposed to open your circle up for the person to come in. So things like that, like what are the cues? And these aren't necessarily things that those without ASD are taught necessarily, but it's something that just becomes it's natural. And so that's something we see as being a difference between the two. And then difficulty forming friendships and in terms of the depth of the friendships that might vary too. So that's the social aspect, like what are the interactions and like what do we see that's a little bit different? And then in terms of the communication, that can be either verbal or nonverbal. So doesn't it just you're going to see impairments in whether the person is verbal or nonverbal or both. So echolalia is one thing that we might see. So kind of this repetition of saying like a phrase of a word at the end of the sentence or just repeating back something. Um, and it's a little bit different than just, oh, I said it a second time to like remember it in my head. It seems very different. It's just this repetition, seemingly without no like apparent reason in terms of it's different if you're studying for a test and you're trying to come up with a mnemonic. That's different than this echolalia of just like repetition of the phrase. And then you also might see pronoun reversal. That's the social aspect. So that's one thing. And that's the thing that usually gets confused with social pragmatic disorder. And then these are the RRBs, which is, again, for autism, you have to meet criteria for both of these things. So the RRBs are repetitive, restricted interest or activities or behaviors. And repetitive sensory motor behaviors is going to be different than restricted interest. So there's like restriction in terms of range, and there's repetition in terms of how often the frequency occurs. So in terms of repetition, when we look at motor behaviors, we see it most often with younger kids, and you see it a lot with people, again, young children with autism and those with lower intelligence in the sense of like what we talked about on Friday with intellectual disabilities. So you might see repetitive motor behaviors, and that might be hand flapping, rocking, twirling, toe walking, repetitive use of objects, and potentially self-injurious behaviors. So this second bullet point right here, hand flapping, rocking, twirling, toe walking, we might call that stimming. So if you are familiar with that word in ABA or family member or anyone you know with autism that demonstrates that behavior, we call it stimming. But what it falls under in terms of the DSM is this repetitive behavior aspect of ASD. That's different and could be in addition to someone demonstrating insistence on sameness. So that's that restriction of range. And we tend to see that more in older children. I would take that with a grain of salt. I think we see it across the board. But this is really a preoccupation with aspects of the environment and wanting it to be the same across time. So what we might see is like the routine, like an insistence on the routine being exactly the same, following rules or like a ritual that you have, like before I can brush my teeth, I have to go turn off my light, or following whatever routine that you have in your family or that the child has made up for themselves. And then being really sensitive to minor changes in the environment because of this restriction of interest, or in terms of their ritual that they must have. You also might see obsessions with numbers or overly absorbed in hobbies. I think this is a good example when people talk about like, my child is so smart. You think, and they suspect there's autism. My child is so interested in, I don't know, Thomas the Train, and like knows everything about trains, and like is really absorbed, but like can't be bothered to do all these other things. I try to show him race cars and can't be bothered with that. That's something that we might ask, okay, is this something that falls within this insistence on sameness um like diagnostic criteria that we're looking at, or is it just more just not interested, which is pretty normal, right, for a 6-year-old boy to be really interested in one thing and then to shift their interest into something else. So as always, we're differentiating between what's developmentally appropriate and to be expected. And if this is beyond that, then this is something we might look at in terms of an ASD lens. So this is what I was saying earlier. There's always going to be additional criteria. So this is what's in the DSM. Criterion A is this deficit in social communication, social interaction, and you need to see it across multiple contexts. And here are some of the examples. We talked about that. And we must have criterion B also being met, where these RRBs are occurring and they need to be at least 2 of the following of these things. C, D, and E, which is kind of cut off at the bottom, are all the things I said earlier, and needs to be present in an early developmental period, needs to cause impairment or distress, and needs to not be explained by some other disorder. Okay, so that's like what the presentation is, what the diagnosis, and maybe what like the presentation of a diagnosis would look like. In terms of etiology, so how does it occur? Again, we're always going to think about the gene, neurobiology stuff, plus environment and how those things interact. So in terms of environment, or sorry, genetics, so neurobiology, heritability estimates are quite high. And that seems to be true for a lot of the neurodevelopmental disorders. So I think autism, heritability rates are quite high. So meaning if there's someone in your family who has autism, or maybe, again, remember it's a continuum, so maybe they had Asperger's or they had some other disorder that falls within this ASD continuum, the heritability rates are quite high. And you'll find that same thing with schizophrenia, which is also considered to have strong overlap in the neurobiology of autism and schizophrenia. ASD risk is highly polygenic, which is, I think, not that it's dumb to put it here, but I think it's a reminder that there's not one gene necessarily that dictates autism. It's a cluster of genes if there's going to be any genetic risk for ASD. So it's going to be multiple genes involved for ASD. I think that's important to say for autism when we're talking about etiology, because I think there's a lot of just a lot of like confusion and concern about different like causes of autism. And so when we're thinking about the genes, again, it's not just one gene. And this is going to translate across all disorders for the most part. There isn't one like gene in particular that's responsible for causing psychopathology. It might be strongly correlated, but in one person, there's no one gene that's going to be associated with a particular disorder like this, unless we're talking about intellectual disabilities, like where we have clear genetic causes, like we talked about last week. Down syndrome, Willie-Prater syndrome, those kinds of things are different. So that's the gene aspect. And then when we're talking about neurological factors, as per usual, there's no one neurobiological anomaly, but we have some studies of what we've looked at when we have people with ASD and those without, and we might see greater brain and head size, higher incidence of seizures, and brain structure abnormalities. In terms of, so that's neurobiology within the person, then we're talking about environmental factors, so what's going on in the community, but also especially within the family sector of the child's life. Thinking about advanced paternal and maternal age. So how old are the parents at the child's birth? Maternal exposure to toxic chemicals, maternal obesity or gestational diabetes, other metabolic factors, and other immune reactions during pregnancy for the mom side. And I don't know how much of this is like anecdotal, but this is also something in the textbook where it says both prenatal and birth complications tend to be common with ASD. And again, though, it says unlikely to be causal, but rather associated with atypical fetal development and risk for ASD. So something we talked about in the developmental psychopathology slides early on in week 2, I think. We talked about how like you can look at someone in a model, here's like the problem behaviors or the phenotypic presentation. It's the thing that parents are usually taking their kids into treatment for because they're noticing these problem behaviors or the phenotype. And then we work backwards and we see, okay, here are all the individual differences. We're never going to know like what gene it is unless you're doing some really high in-depth research study that is assessing all of that. So all of that is just, we're capturing it on a record form. So if I'm asking you on my form and I'm going to assess you, is there any family history of medical problems, any family history of psychiatric disorders? That's where they're going to put it. And there's also often a section for any developmental milestones and birth complications. So it'll say, when was the child born? 28 weeks, they were preemie. Okay, that's something to keep in mind. They had to stay in the NICU for 3 months. Okay, that's something I'm also going to know. There was hypoxia during birth. There was a birth complication. So all these things are going to be noted, and we're going to conceptualize that when we're giving an assessment and when we're giving a diagnosis. We're going to keep those things in mind. And we know that it is really common to see these kinds of things, so prenatal and birth complications, when we are looking at people with ASD, but also same thing with other intellectual disabilities and other communication disorders. So again, it's always going to be like, what is, you're looking at someone, what they're coming into you for in terms of the presentation, and you're always going to consider all of these things. But for ASD, we think about it especially. Here's another thing, which is why we're spending so much time talking about etiology. Vaccines do not cause autism. That's something that has been talked about for at least 2 decades now. And I'll put it here. You can look it up on your own, or I can find the article for you. But the article that was published in The Lancet that drew speculation in the first place between the MMR vaccine and pervasive developmental disorder, which is today's term for autism, was retracted. It was really bad science. There was only 12 children in the study. The doctor lost his medical license because it's untrue. And there's been a lot of research literally in the last 2 decades and more just trying to show evidence that that is not the case, that it's not, vaccines are not associated with any risk for any vaccine or autism. It doesn't have to be the MMR, it can be, I mean, I don't know about, so there's not a lot of research right now on COVID, but thinking about all the vaccine history, your vaccine medical card, all the history that you have to have on there, just however many shots you're supposed to take, that's the one that has a lot of research in the last 20 plus years showing that there's no link between vaccines and autism. So that's one theory that has been debunked. Here's another the annual reviews is a really good, if you're ever like asked to like read a paper for a class and there's like a topic of interest, the annual reviews is a really good like summary, and it's probably like 18 pages, maybe less, maybe more. But it's usually like a pretty succinct summary of a lot of research up to that point. So the annual reviews, I would say, is a really good one for, I don't know, like a lot of neuro type stuff and psychopathology go in there. So I think it's a good thing to look at if you're interested. But again, here is the annual review of virology. This is one that came out in 2019, and it was a synthesis of all research that has been done on any associations between vaccines and autism, all of them repeatedly showing that there was no association. So other debunked theories, there used to be this thing called like refrigerator parenting where people were saying that it's really a mother's insensitivity or inadequate parenting that causes children to retreat, and then this is literally from your book, retreat into an autistic empty fortress. It's just one other debunked theory. That refrigerator mom, like mothering, is thought of like a cold. If do you guys remember the rhesus monkeys, where there was like the cloth mother and the wire mother, and the monkeys would go to the cloth mother even though it didn't dispense food. The wire mother is the one that like met the biological needs of like needing to feed the baby, and the monkey would go into the cloth mother instead to get comfort. So this idea of like refrigerator parenting is like the wire mother that like it feeds you, but there's no warmth or anything like that. So this was something that was discussed like decades ago, and there's no research showing any evidence of insensitive parenting causing autism. Now, we might see like differences in how parenting looks between different types of moms, but again, that's not going to be the cause of autism. So that's another debunked theory. Okay, more common in boys than girls. This is a pretty common theme that we've been seeing so far when we look at prevalence rates. And I think that's also just the setup of what we've been looking at, but most of these have a higher prevalence rates in boys. And then when we start looking at the rest of the like areas of psychopathology after exam two, you'll see that some of those numbers reverse. But for now, everything we've talked about has higher prevalence rates in boys than girls. And those prevalence rates, as always, are going to vary based on a lot of different things. There's differences in the diagnostic criteria. So if you were doing prevalence research, epidemiologic research, prevalence research 35 years ago, the diagnostic criteria that you were using for autistic disorder is not the same as what we're going to see with autism today. So changes in diagnostic criteria, there's also a lot more awareness and support for families who have a child with autism, for what kind of services they are eligible for. So that I think also changes things. Um, this is a more recent note. So COVID-19 impeded earlier diagnosis and intervention. Um, so not being able to get out and like go to the doctor or get an assessment. And then incentives such as funding for diagnosis leading to inaccurate diagnosis. So that's something that your textbook puts in there as like there are a lot of like movements at different times when it comes to federal funding to spend time looking at a specific disorder. And so this is just saying there was a big push at one point to do autism research. 3-to-1 ratio, again, this is more common in boys and girls, and it looks like that across countries. It doesn't seem to be specifically a Western thing. It seems to be worldwide. So it's male sex is a risk factor, and there's a underdiagnosis in girls. I'm going to save this video for after. Okay, developmental course. So what does it look like across time for a particular person? So your book says that there are 3 common patterns of onset. The first one is that the abnormalities become obvious in the first year of life, which is true for most children. So you're noticing it pretty early on. So again, in that early history that I'm taking where I said I'm asking, what are your developmental milestones? Did they meet the walking milestone? Were they sitting up by so-and-so age? Were they rolling over at so-and-so age, right? Looking at all the developmental milestones. Those are the things that parents might say, like, no, like didn't start talking until they were like 4 years old. Most babies start babbling in the first year of life, right? Like I think like like pretty early on, and you start saying your first words by 1 year old. So my child wasn't talking until they were like 3.5 years old. That's going to be an obvious delay, and that's what we mean by abnormality. So I made an exaggeration and said all the way up to 4 years old, but because the absence of babbling or talking is happening in the first year of life, that's usually a signal that something is maybe awry. The two other patterns of onset. So the second one says typical or near typical development is followed by arrested skill acquisition and loss of previously acquired language, social, and or motor skills. So we're calling this regression. It seems as though they met all their milestones on time. They were walking when they were supposed to be walking, talking when they were supposed to be talking. They seem to be engaged in like joint attention tasks. And then at maybe like 4 years old, all of a sudden it feels like it regressed. They stopped talking. They stopped enjoying joint eye contact activities, things like that. So you saw some trajectory for typical development and you saw instances of typical development, and then something happened and there was some sort of regression taking place. Third one, mild delays until about age 2, and then gradual or abrupt developmental arrest and plateau. So there were abnormalities to begin with, but it was quite mild. It could just be, oh, they started talking, but it was like, I don't know, 6 months after the norm. Okay, and they see that for most milestones up till age 2. And then similar to the second one, there's some sort of noticeable time point where things start regressing or just doesn't improve at all. And that's what it means by plateau. It doesn't improve and it just stays with that for the rest of the time. Again, the first one tends to be the most common, but that's not to say that these other things don't occur. I just think this is when you meet most families in an assessment setting or in an ABA setting, they're usually quite young, and it's usually this first thing that drives them to get there to ABA or to get an assessment. And while behavioral symptoms may not emerge until later childhood, ASD is present from early in development. And so we know that ASD can be reliably diagnosed by age 2 because of all of these early risk factors and all these early markers of what could be autism. So you may not see repetitive restricted behaviors in a 1.5-year-old, but we're going to see other instances or other symptoms of ASD that could be reliably diagnosed, which points to early identification and diagnosis being needed to then get treatment. And if it's not ASD, it could be something else. Even then, still getting diagnosed and treatment for whatever it is going to be really, really impactful at 2 years old versus 12.5 years old. And then despite modest improvement over time, symptoms generally persist into adulthood for most people with ASD. So this is what we talked about last week with intellectual disabilities. It's chronic and it's lifelong, and that this is just something that you have, that you live with, but the way that the quality of life and the functioning can be modestly improved over time, but we're going to have these symptoms that we're always going to have to manage. And this is also just talking about autism in an isolated sense, so just autism. But if we're thinking of autism plus some sort of intellectual disability, plus some sort of like mood disorder, anything like that, that's going to look different than just autism in and of itself. So then that leads us to treatment. What is the cure? There is no cure. Really, therapy is not to cure the symptoms of ASD. We're not trying to cure social deficits. It's just to improve functional outcomes. So if we can improve your quality of life, your symptomatology, if we can reduce it, that gives you more tools to navigate life, to have a higher functioning life, have a higher quality of life. If you're a child and your parents are taking care of you, it helps parenting, it helps just a lot of different aspects of well-being, and it reduces adverse or harmful behaviors. So an example of harmful behaviors is if the child, gets dysregulated, and when they get really, really upset, they're head banging. That's really dangerous. That can cause a concussion. There's a lot of harm that can happen when we just let it be. When we just say, okay, you should just, okay, go ahead, keep hitting your head. That's not going to end well. And so treatment would include like, how can we substitute that behavior, or are we able to reduce the behavior entirely? So that's just functionally trying to reduce something that can be harmful to the child's life. In terms of like social communication, this isn't to say like, don't talk the way you talk. It's just if we want to improve the quality of life, and that's and we're seeing a pretty big deficit in the way that someone's communicating in other social contexts, having tools for how to navigate that is going to improve functional outcomes and quality of life, and especially the family well-being. All of these treatments tend to be behaviorally based. Those are the ones that have the most evidence base and are the most empirically supported intervention for ASD. You'll hear a lot, and we've talked a lot about this already in this class. ABA, applied behavioral analysis. I think I have a slide on this. There's some controversy and just like feelings about ABA as a practice, but in terms of the like behavioral components, that all stems from behaviorism, which is what we use for a lot of different disorders that are not autism. We use it a lot for ADHD. It's all behaviorally based. Parent management training is about enhancing the parent-child relationship and then also implementing behavioral aspects using reinforcement and consequence as ways to enhance your behaviors to help prepare your child do better. So that's all behaviorally based. Exposure for when you have anxiety. Most of your therapeutic interventions are going to have an exposure component because we know that when we avoid something that gives us anxiety, we reinforce it in the long term. We get short-term relief, but in the long term, we're just reinforcing that like you are going to you're going to have an intensity spike, if you will, with whatever emotion you're feeling in the face of the stressor that causes the anxiety. The therapeutic intervention for that, with the most evidence base, is exposure, systematically exposing yourself to that stimuli and using management techniques to be able to get through that exposure. So, all of these things are based in behaviorism. We know that that's the first movement away from psychoanalysis. So there's a lot of evidence and rich history in behaviorism. ABA is just one other example of using behavioral principles of operant conditioning, and it does include punishment. Um, and I think where there comes controversy is ABA is not just behaviorism, it has all of these like different models of like discrete trial training, just the ways that they implement ABA have been subject to controversy in I think different communities. And so it's really the use of punishment that gets discussed a lot in, I think, the controversies. But in terms of the actual what the other principles are, I think all of that is rooted in behaviorism that's used across multiple different treatments. So again, the evidence base is not the thing that I think is at question here. And it's not at question in terms of research either. It's more about like how people feel about implementing punishment or using principles of operant conditioning. And keeping in mind where you're talking about behavior terms, so not punishment like spanking or like, I don't know, taking away TV time. It's punishment in the sense that we're trying to reduce the behavior, and we can use either positive or negative stimuli, increase or decrease of the stimuli to then get our behavioral outcome of reducing whatever the behavior is. So I think people struggle with that. And it's interesting that we also use punishment quite liberally, I think, in most households for taking away TV time because you don't want the kid, you ask them to do something, they continue to do it. The behavior is what you want to reduce. And so you take away something. We're taking away, that's negative punishment. It's quite frequently used. So some variation of that gets used in ABA. And that's the thing that I think people feel really uncomfortable with, as well as I think just different feelings about when you talk about like social communication, how we're trying to improve that. Is that taking away from the person's individuality? And I think there can be a case made for either side. But I think the premise of ABA when it comes to that is just to give the tools. Um, and then again, the way that it's implemented is the thing that gets like people feel differently about. Um, okay, so that was ABA. And then your textbook has the rest of the interventions listed. It's like 5 pages worth. I would just skim it. I think really like knowing diagnostic criteria for ASD is the most important, and knowing that ABA and just the behavioral principle components are the things that we are talking about. Those are the things I would say are most important for your knowledge in the exam, but there are other interventions which you can skim in those 5 pages. Okay, so here's a case study. So I just want you to think about like the general two-pronged criteria. So criterion A is having some sort of social communication / interaction deficit. The criterion B is those RRBs, and it can either be repetitive motor behavior or sensory behavior, or it can be restricted range of interests or ability to expand past their usual ritual. So those are the two things you're just thinking of in mind and reading this vignette, thinking about, does this person perhaps meet criteria or like a pretty good example of someone who could be referred for a diagnostic assessment. I'm gonna take a sip and then I'm gonna read it. Okay. JR is a 2.5-year-old multiracial boy. He is the only child in his family. He's currently nonverbal and has been able to unsuccessfully toilet train. JR rarely makes eye contact and does not respond to his name. He's extremely averse to certain tastes and textures and will currently only eat crackers, pasta, and Cheerios. Since he was born, JR has been sleeping in the same bed as his parents, must be rocked to sleep every night, and wakes up several times during the night. When his parents need to make any changes to his routine, he gets very upset and cries. JR also gets very upset when he sees other children crying, laughing, or making loud noises. JR loves the alphabet and will spend hours putting his alphabet set in a row. He gets very upset if anyone tries to move his toys and does not seem interested in playing with others. JR is extremely affectionate with others, but does not demonstrate any stranger danger and will often get uncomfortably close to others. When he's excited, he will roll back and forth on a couch or other object. Okay, I'll let you think about that for a second, and then I'm going to ask if people have any thoughts about, are you noticing any symptoms? And if you are, what is it that you're seeing? Okay. Anyone seeing anything in what the vignette is showing us? Any, like, let's start with like social communication slash interaction. What are we seeing in the first few sentences that communicates to us whether or not there's something looking a little bit different?
That he's nonverbal.
Yeah, excellent. Yes, nonverbal. He's 2.5. And so definitely by 2.5, we're expecting, sorry, we're seeing, or excuse me, we're expecting some sort of communication. Um, Even if it's like babbling or like one-word sentences, it seems that we're not seeing any communication. I also see here he rarely makes eye contact, does not respond to his name. So that's something we talked about earlier. So just failure to respond to name, hold eye contact, or make eye contact. What else?
The repetitive play of like putting his alphabet set in a row over and over again.
Exactly. Yeah, that repetition of, I think that's something I forgot to mention it, but you often see lining up toys or kind of putting them together in an order. So we see that. Um, what do you all think about having an aversion to certain tastes and textures and only eating these three things?
I think
Is
that
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 it?
would be like considered a sensory issue, right?
Yeah, exactly. So the taste and texture thing is yeah, definitely a sensory thing, which falls under the RRBs. And then that leads to him to only eat these three things, which still also falls into the restriction, like, or it could be a consequence of the sensory sensitivity. But yeah, so now only eating those three things is pretty restricted. Um, I'm just gonna move quickly too. So sleeping in the same bed as his parents, needing to be rocked to sleep every night, wakes up several times. We tend to know that across the board, not just autism, but most mental health disorders, there tends to be a sleep component where there's pretty low quality of sleep or the sleep is being disrupted. And in most of them, we'll see some sort of, in most of the disorders, we see a criteria where there's a comment on sleep. And even if there's not, we know typically when sleep is impaired, we're seeing a lot of other things happen. So yeah, having this like ritual of having parents rock him and even then getting up several times during the night is going to make him sensitive to whatever his sensory aversions are to begin with. So things like that also are important to note. We know that when his parents make any changes to his routines, he gets really upset and he cries. So all of this to us is pointing to some sort of there's impairments in the social communication realm and the repetition realm, so the RRBs. Um, this one I think is interesting too. I think people, well, not everybody, but I think a lot of times people think of children with autism as being not affectionate at all. And this is an example of that's not true. We could see extremely affectionate with others, but then doesn't demonstrate any stranger danger, which is also problematic, right? So we do want to instill a healthy amount of what's who's safe and who's not safe. So hugging mom inside the home is really different than when you're walking at the mall and you hug some random person walking next to you. So that's an example of that. There's this indiscriminate affection with different people is also an indication of some sort of impairment in the social communication interaction domain. And when he's excited, he rolls back and forth on a couch or other objects. So that's, again, that repetitive sensory motor behavior, what we would call stimming. Exactly. I think you all got all of it. Yeah, and then this, oh, I forgot to mention, he has been unable to successfully toilet train. That could just be an example of where JR stands in terms of developmental milestones. They're embarking on it and is struggling. So I can't remember what age children need to be potty trained by, but definitely by 5 when you're putting, or 4 when you're putting them in preschool and kindergarten, there's already an expectation that they're potty trained. So 2.5 years old would be right on par. But this to us in terms of the vignette just might be an indication that this might extend past 5 years old or whatever. Okay, so this was just putting it back into the context of the DSM. All of this is true. That's everything we marked. And okay, let me just close this really quick. I want to see how many slides we have. I like desperately need to make sure I have time to get to my meeting. Okay. Okay, we have uh, like 10 slides. So what I'm going to do is I'm just going to save the 10, 11 slides for Wednesday, which is actually exactly what I was planning in the syllabus. So, okay, that's it for today, I think. Let's just stop here because that's the autism section. We'll end with schizophrenia on Wednesday, and it's only like 10 slides. And then we can end class early on Wednesday, or we can go straight into an exam review, whatever you all prefer. But I think I'd rather just make sure we have enough time to talk about it next week rather than cramming it into today's lecture. Um, any questions? Oh, thank you for answering in the chat. Any questions about what we talked about today or the plan for this week? No. Okay. I think it's